Good morning, everyone, and welcome to the Informing COVID-19 Response with Location Intelligence webinar. My name is Robbie Deming, and I work on the media team at Esri. This webinar is part of the Health Information Technology webinar series Esri is hosting over the next few months. We'll be sharing some information about those webinars later on during this session. You've all joined the webinar in listen-only mode, which means your microphones are muted for the duration of the webinar. That said, we absolutely want to hear from you and encourage you to submit your questions into the chat at any point during the webinar. We will have a live Q&A at the end of today's session, and we'll do our best to address submitted questions. This session is being recorded and will be sent to you shortly. We'll share a survey at the end where you can provide your feedback on this session. If you can spare a few minutes, we would really appreciate your perspective and would love to hear from you. I mentioned that this webinar is part of a series of webinars relating to health information technology. We'll be holding webinars in May and June that explore other ways health-related organizations use location intelligence that extend beyond today's topic of COVID-19 response. Here's a quick rundown of today's webinar. Dr. Este Geraghty will kick things off with a discussion of resources and workflows organizations can use to respond to COVID-19. Dr. Dora Barilla will then share some insights about location intelligence and social vulnerability, as well as her organization's experience on the front lines of the COVID-19 response. Dr. Geraghty and Dr. Barilla will wrap up with a quick discussion about vulnerable populations and moving forward before taking questions submitted by the audience. With that, I'd like to hand it off to Dr. Geraghty.
Thanks, Robbie. Let me just get everything set up here. All right, so I know you're seeing my webcam. Let me see if I can get you to see my slides.
It looks like your slides are showing.
Oh, okay, but I can't see them, so I'm gonna have to switch something around here. Now I can see them. Are you still seeing everything you need to see, Robbie?
Absolutely, looks awesome.
Perfect, thank you. Well, hello everyone, and thank you for joining us today for this discussion about how a location intelligence approach can support a robust response to COVID-19. Now, I have to say that we are certainly living in interesting times, and that probably goes without saying, but so much is different in today's world. Our challenges have changed so that we have this new kind of a dilemma. Data is actually much more plentiful than ever before. You no longer have to rely solely on the data that you have individually been able to curate and collect. There are literally hundreds of thousands and perhaps millions of geo-enabled health data sets that you can access at any time. However, despite our improved access to data resources, understanding has never been more challenging. Here's some stats on that. Do you realize that 80% of an analyst's time is spent searching and processing data rather than actually analyzing it? Similarly, 60% of a data scientist's time is spent curating data rather than producing accurate models. When it comes to decision making, we know that less than 50% of structured data is actually used in making decisions, and worse, less than 1% of unstructured data, things like reports, emails, and documents, are ever used in the decision-making process at all. But there is an answer. Map it. And I actually mean that literally, because when you put your data on a map, things happen. Patterns start to get clearer. Relationships become a bit more obvious. And with geography providing that contextual information for your data, we can make greater sense of it, create new insights, and actually see the forest for the trees. That helps us to get answers to our important questions. And we call this location intelligence. And actually, it truly does help you to see what others can't. Now, the technology that supports developing a location intelligence is a geographic information system. And today I want to share with you how this is truly an enterprise system for pandemic response. It's being used broadly from health responders like the World Health Organization to university researchers to disaster agencies like FEMA and the US military. And hundreds, if not thousands, of local governments like St. Johns County, Florida, are taking advantage of the tools so they can support their populations in a holistic way. Now, if there's anyone on this webinar who's not very familiar with GIS or thinks of GIS as just a map, I want to assure you that a GIS is a comprehensive and integrated system for all sorts of critical workflows. A GIS provides a framework and a process that begins with data measurement, which we then want to be able to visualize and analyze for a deeper understanding, to be able to get to those important stages of planning, decision-making, and action. Now, in the unique case of COVID-19, there are some more specific information products and data sets that might be used in this particular workflow model. We measure things like healthcare facilities and cases, demographic information, and our vulnerable populations. We communicate with strong mapping and dashboards. When we get to the analytics, we're looking at things like forecasting and understanding impacts. We do intervention planning, like social distancing, to stop the spread of the virus. And then we do testing and treatment, focusing on site selection and choosing the right locations for these kinds of resources. And GIS helps allocate where we put equipment or personnel based on those needs or the forecasted needs. Finally, it is a collection of tools that help us to engage our communities, and it's absolutely data-driven and science-based. So, where do you start? Well, I've developed this 5-step framework for understanding the impacts of COVID-19. I think just about anything that you would want to do with GIS for this pandemic can fit into one of these 5 areas, and they are: map the cases, map the spread of disease, identify and understand the vulnerable populations, map your capacity in your system to respond, and communicate with maps. So I want to take a few minutes to look at how some are operationalizing all of these steps. So first, when I talk about mapping the cases, I'm talking about the confirmed and active cases, the fatalities and the recovered cases. You need this information to get an overview so you understand the current situation at hand. I mean, for overall situational awareness, no one dashboard has been relied upon more heavily than the Johns Hopkins University dashboard, which has literally been requested over 1 billion times since the beginning of this crisis, and it's built on Esri dashboarding technology. Step 2 is to map the spread of disease. Now, epidemiologists often look at the number of cases per day as a way to see the outbreak's distribution over time. What I'm suggesting when I say map the spread kind of takes that to the next level and adds the geographic spread as well, because when you know the direction of spread and that pace of disease spread, you can determine when and where to target your interventions, like shelter-in-place instructions. This example that you're seeing comes from the University of Virginia's Biocomplexity Institute. It's a really good example because you can see the day-to-day time slider across the top, the number of new cases per day in the graphic on the left, and then the mapped cases over time in the map area. Now, step 3 is about mapping vulnerable or higher risk populations. Now, some people are going to be at higher risk of the more severe disease, like older adults and people who have chronic medical problems. Some may be at higher risk for transmitting disease, like people who live in high-density populations. These and other relevant factors are distributed differently across our communities. So let me show you some examples from Kansas City, Missouri for this step 3. Now, this first map is showing where we have high numbers and high percentages of seniors across the community. And in this case, we're looking at population density, where the lighter colors are higher density areas, and therefore more likely to have interactions among the residents. The CDC has made their social vulnerability index available so that we can look at this single index that provides 15 different measures of social vulnerability so that you can see the areas of highest concern in the darker blue color. And this last map, we are able to see in red the areas where we have a greater proportion of the population that lacks health insurance. Now, once you understand your vulnerabilities, you'll want to determine your capacity to respond. For example, here we're looking at New York City, which has been in the news quite a lot lately. And across the top, you're seeing some basic information related to the population, the number of households, median income, and median age. Now, the next section is interesting. It's based on the CDC's predictions for infection rates, hospitalization rates, intensive care unit needs, and fatality rates, but they do it by age cohort. So they've provided low and high range estimates that we simply carry through the math for the local population characteristics. So this kind of information offers some insight into a jurisdiction's overall capacity needs throughout the duration of the event. Now, this is another example of mapping capacity, and here we're seeing Jefferson County, Tennessee, and their hospital bed capacity information, which, by the way, I want to call out Definitive Healthcare, which is an organization that has all sorts of information about hospitals and healthcare providers and insurers, and they have made all of their hospital bed data available for free throughout this crisis. You can find it on our website, which I'll introduce to you later. But basically, Jefferson County, Tennessee took this data and pulled it into an application. So you're seeing the county boundary, and then there is a hospital there. I'll make it a little more visible. It's purple dot in the northwest part of the county. And what we can see is that this hospital has 58 staffed beds. Now that's not a lot. So if Jefferson County was starting to see a lot of cases, they would want to look at their neighbors to see if maybe they would be able to handle the overflow. Now here we can see the University of Tennessee Medical Center has 609 beds in their system. But actually, we can get a lot more analytical in step 4 and the idea of mapping capacity. Now, in this case, I'm using data from the state of Florida because they've been really great about open data in this pandemic. And what you're seeing here is the CHIME model from University of Pennsylvania Medicine. This is one of a handful of models that is meant to help organizations, jurisdictions, or health systems figure out when their capacity may be exceeded in terms of hospital beds and ICU beds and ventilator use. Now, what you're seeing is the result of scenario planning. You have two curves, one with good social distancing and one with more liberal policies. The curve is flattened and the peak of hospital bed need happens later in the good social distancing model. No surprise, but now we can look at dates and times. Now, the maps are showing you the places where the needs are going to be greatest across the state in the different scenarios. Now, that fifth basic step that I wanted to share is communicating with maps. Many of you are already doing this. For example, Valley County, Idaho, and Leon County, Florida are both thinking about businesses and how they're impacted and how they've adjusted their business models so that they can be more resilient in a difficult time. Many jurisdictions are providing public information about things like school and event cancellations. Now, many of you may think, well, that's old news, but remember that as we reopen the economy, the opposite information is going to be really important, like which schools have now reopened, which events are rescheduled. In Boone County, Missouri, they've used these county impact planning reports that we created to gain insight into the community characteristics that will help with planning and response. And the state of Maryland is showing a dashboard by zip code with lots of great information. The state of Alabama has implemented a testing site locator so that people can find their nearest testing center. And early on in the crisis, the state of Oklahoma shared nationwide airport impacts to bring awareness to travelers across the country. Now, these 5 steps do all fit together to support critical decisions in kind of an additive and iterative way. So you begin with your reporting of cases and you consider the overall community risk. This combined data informs your social distancing policies. You can use geographic information to then understand the adherence to these policies, while also then adding your hospital capacity data so that you can forecast future needs or that surge event. That information then feeds into your decisions about augmenting or allocating new resources to support your forecasted need. So let me speak for just a minute about the information model for this work. Based on our interactions with customers over these last 10 to 12 weeks, these are the data sets that we understand will be most useful to you. So starting with demographics, you definitely want to collect those socioeconomic factors. Age is clearly important. We're learning more and more about racial disparities, so we need to include race information, health conditions where we have pockets of lots of comorbidities. We talked about vulnerable populations and things like housing density or population density. You also need to collect the information about the cases. The confirmed cases, who's hospitalized, requiring higher level care, and who is recovered and who has passed. We need to keep track of testing, the confirmed positive, confirmed negative tests, and those that remain unknown. Hospitals need to understand their service or catchment area and their utilization rates. So their overall capacity, their current occupancy, and their current equipment usage like ventilators. Then, although this is not a nascent data set, it's a calculated data set, it's that forecasted need. You need to be keeping track of that and remodeling that to find out when your peak will be for the number of hospitalizations and beds, as well as the duration of that event. Then there's the social distancing restrictions. They're varied across the country. So understanding how those restrictions differ from place to place is important. It could be something as simple as school and event cancellations to requests that people only perform essential travel for goods and services, or shelter in place instructions, or the most strict, of course, which would be a quarantine. You can start to understand the adherence to those policies by looking at mobility data. We have a lot of those data sets available on our website. I'll show that to you later, the website information. So we can look at the net change in people's movement over time. So what that does is it looks at cell phone data to see where we are currently versus a pre-COVID day. That helps us to understand the effectiveness of how we are social distancing in very small neighborhoods. We can look at people's average distance traveled, which we expect to be less. People confined to their local neighborhoods to go to the grocery store or other essential services, and an increased percentage of their time spent at home. But then when we think about augmenting services, we have to consider what are the candidate sites for those types of services. Where would we put them? Well, you may need to expand hospital capacity in alternate care sites, which could be decommissioned hospitals or decommissioned prisons, for example. Could be university dormitories, hotels and motels, or ships. I think we've seen a lot of these things in the news. Testing sites might have slightly different requirements, right? You might want places that have really good ingress and egress for people doing drive-through testing or walk-up testing. So large parking lots may be useful, or convention centers. So next, in again, kind of a workflow model, I wanted to show you how a bunch of these different data sets are put to use. So site selection is actually a very common workflow in GIS. I will say in this special circumstance, there are several elements to take into consideration in what I'm calling a two-step process. So you may want to determine optimal locations for a number of things. It could be testing sites. Again, those need good access for high throughput and maybe drive-through and or walk-up capabilities. If your hospitals are going to be overwhelmed, you might be looking to site alternate care locations that they need to be able to provide overnight care. They should be separated from hospitals but still have access to medical personnel. And they need to be able to be suitably equipped for this particular disease. You might also want to find the best locations for food or resource distribution sites. These are probably a little bit more like the testing sites because they probably have to be high throughput with drive-through and walk-up capabilities. So different kinds of locations, as we talked about in the information model. So let's look a little bit more closely at the population demand piece of this. This is step one in the site selection model for COVID-19. The idea here is to create a risk surface for each of these risk types. There's transmission risk, socioeconomic risk, susceptibility to the disease risk, exposure risk, and resource insufficiency risk. Now, you don't have to use every variable that I've listed here, just the ones that maybe you have available for your community or that you believe are relevant to your community's situation. In the end, you'll be able to provide a risk ranking over small geographies like block groups or neighborhoods. Now you can see I have a link that says Learn How here. I'm happy to include my slides as a resource when we send out the video recording of this presentation so that you can actually take a quick lesson on how to build these risk surfaces. And I also have a lesson for step two of the two-step process, which is the location allocation piece of this. Now, to calculate location allocation, you'll need access to some road network data, and the inputs for this model are the risk surfaces from step one. And then you also add any of your supply chain capacity constraints. That means that maybe you only have the budget for 10 facilities, or you only have staffing or administration available for 10 facilities. So you can constrain the model to only select the top 10 optimal sites from the entire population of candidate sites that you make available. Now, there's also the possibility that you would say just select every site that meets all of my predefined criteria, and then we'll figure out how many of those we could do, so you constrain the model a little less. But the way this model works is that it weights the travel distance from those highest demand neighborhoods to your candidate sites to select the best match. Now, once your decisions have been made, you're not quite done, right? You want to have some sort of dashboard and metric reporting as you move forward with those chosen sites. So you can see how you're tracking progress on standing up the different sites and monitoring the ability of each of those sites to meet your ongoing population needs. So as kind of a review, how do you take action? Well, you start by implementing the COVID-19 information model, and we are already curating most of the data that you're going to need for that. All you have to do is use it. And then you begin your community risk analysis. So you're going to look at the social distancing data. You're going to see if it's flattening the curve in your jurisdiction, or maybe you find out that you need stronger interventions or different messaging to really get the point across. You're going to keep an eye on the daily spread of disease as you run your forecasting models for hospital bed capacity. And then, as needed, you'll cite new locations for your new resources, like testing centers or alternative treatment locations. Now, I know that I've already given you quite a lot of information, and it's possible that in this current situation, maybe you have technical constraints or time constraints, and you want something that's really quick and easy. Well, we can certainly help with that as well. We've created 3 solutions that you can download and use right away. Now, the first one is called the COVID-19 Response Solution, and that one is going to help you to report, track, and monitor coronavirus cases in your community. It's going to allow you to track the changing status of public gathering places, like we talked about, like schools and government facilities that may have closed or changed their hours. You'll inventory the places where people can get testing and treatment, like the testing sites, hospitals, and clinics. And then you'll be able to make all of that information available in a public-facing app so that people are aware of what their resources are for testing and treatment and the changing hours of schools or public gatherings. Now, our newest solution, just put out a few days ago, is specifically for hospitals to be able to easily report to the feds their hospitalizations and personal protective equipment inventories. Now, this solution has first a survey tool that records and reports the data. And all data are connected automatically to 2 dashboards that allow the hospitals to get a comprehensive view or overview of their cases per hospital or as a health system, as well as their PPE inventories. Now, the third solution we've called the business continuity solution, but don't let that be misleading. This is for everybody, and it's critical for helping organizations of all kinds to manage their employees and their facilities and their external communications about any ongoing changes with their business during this time and the way that they provide their services. Now, all of these solutions come with software and support services and truly everything you'll need to deploy and use them quickly. And I don't think I've mentioned it yet, we're offering all of this at no cost during this pandemic. Now, as you think about using GIS to address the COVID-19 pandemic, know that the technology, it's here for you to use. It works very, very well. Often technology is the easy part, but this really requires more than technology. You need a strong champion and leadership to make things happen, right? You need to know your mission, and that's going to drive your strategy. And I would say that you really need the questions that you're asking of technology to be clear and focused on your most important issues. Your internal governance processes are critical for how you're going to share data internally with your partners and with the public. And of course, there's an important role for your GIS professionals in this work. Now, all of the information and tools and data resources and even detailed guidance that I've discussed here today and much, much more are all available through our Esri COVID-19 GIS Hub site. This is where you can request the solutions or whatever you need. You can see that request GIS assistance is right there in the middle. So I suggest taking a screenshot or copying down the URL and checking back often because we're adding to this website every single day. And with that, I have to say, it's my great pleasure to turn over the mic to my friend and colleague, Dr. Dora Barilla, the Group Vice President of Community Health Investment at Providence St. Joseph Health. So Dora, let me pass it over to you.
Wonderful. Well, good morning, everyone, and thank you, Este. It's really a pleasure to be here today as we talk through, some of these opportunities with, the amazing technology. But I want to start a little bit about our story within Providence St. Joseph Health, and there's really multiple stories within the COVID-19 outbreak, and many of you probably have heard that. One of the first confirmed cases, although recent research is showing that it might not have been the first case in the United States, was in our service area in Washington in one of our facilities. But I want to share a little bit about the overall background and our size and footprint of Providence St. Joseph Health, because this is really relevant when you're talking about really looking at location intelligence. We really want to be smart in terms of thinking of our technology. And so Providence St. Joseph Health has a 7-state footprint. We have 51 acute care hospitals, and my portfolio is we have $1.6 billion in community benefits that we invest in our local communities. So the story that I'm going to share with you today is really that community health story and how that interacts and connects with within our internal team. And what I love about what we've begun and what we started here is really the vision of our President and CEO, Dr. Rod Hochman. And he consistently states of how we have to be big and, being one of the largest health systems in the country, and then small at the same time, meaning how do we really serve our local communities? And location intelligence and our partnership has really enabled us to do that in a far more effective way and beginning to look at, some of the data in terms of, how we're using all of our technology. So I am, we're working through all the technology pieces here. So thank you for your grace in terms of, how do we work all of this. I want to share, this is really before COVID, because I think this is important in terms of adoption of technology, that, when there's a crisis, people often revert to the norm. And as we think about, having the, really the capacity and the infrastructure that SD talked about in terms of, having the individuals being able to make the decisions, having the data. We had started this about 18 months ago, and what we were looking at is really a modernization of our community health needs assessments, which most not-for-profit acute care hospitals are required to do every 3 years. And this is really core to our mission in terms of serving the poor and the vulnerable. So this isn't only a requirement, this is core to our mission to knowing our communities, because you can't serve those and really be impactful to those that you don't know. So we had started what we call our modernization to make our community health needs assessment become alive, become actionable, not something that we collected data and put on a shelf, but how do we really begin to know our community? So we began this process of, adopting a lot of the, GIS technology within our community health needs assessment, so it can be more interactive, that we can really have more of a community-facing resource, that we can partner with our communities, because we know we don't improve overall health unless we're doing it in collaboration with our other partners. And then, really looking at one of my visions is to how can we make the community health needs assessment one of the most strategic documents in the organization. That really requires a data analysis at another level, really being able to do some planning, most importantly, being able to make those decisions, and then utmostly, how do we have action with the data that we're collecting? As Este mentioned as well, who are our high need areas, who in our communities, in terms of not only as they come into our hospitals and into our health facilities, but where in our communities. We know that, zip code is just as important to health as, often your genetic code. So really knowing those areas ahead of time are, what are some of the socioeconomic issues? What are some of the age, the previous existing conditions, the race, other elements in a community or community conditions that really require additional interventions and additional investments, so that we can not just, spread peanut butter with some of our investments, but really have a target and understand who our key partners are, and then to understand and really be able to evaluate, are our investments having an impact in our communities? So we had begun this process about 18 months ago and began to adopt our technology. So we are really fortunate. My data team is absolutely fabulous. Megan, Josh, and Catherine had begun to, be the back end of a lot of the data with our community health needs assessment. And that prepared us. So when COVID did hit, at the end of February, beginning of March, we all know it came like a wave. And although it's only April 23rd, it feels like a year ago. As we had that first case, at least confirmed case, at our Providence Regional Medical Center in Everett. And we instantly leveraged the technology that we had already put in place. So really knowing that our location intelligence was going to be so important. Really understanding who was vulnerable, and that continues to evolve. Originally we thought it was, mostly the population age 65 and plus, but we also looked at the CDC Social Vulnerability Index, knowing that, there was some indices and some indicators that would give us some intelligence and knowledge on, who was going to be, impacted by any disaster, and to have that intelligence in our back pocket for each one of our communities. And who needs us? Who needs us the most? Because we can't be everything to everyone, but we certainly want to be sure that we're serving the poor and the vulnerable, that we know who's going to be impacted, not only in mitigation, but also looking at recovery, that I'll talk about in a moment. And then who are our partners, and where is that, where do we need to leverage a lot of the existing partners that we have where are the resources that we have in our communities that we can begin to think about, some of the food distribution, looking at some of those basic resource needs that many of our vulnerable communities needed. So what we did is we really leveraged the dashboard, as Este mentioned, the Johns Hopkins dashboard, what we could take existing data so that we didn't have to start from scratch. So what we did is we mapped all of our 7 states, beginning to look at where are the confirmed cases. And this was, again, in that initial outbreak, as we put together the slides, I'm always shocked at, the changes in some of the numbers and confirmed cases as, they rapidly climbed, that we had real-time data of what was happening in our community, overlaid with some of the basic information about who our community is, who lives there, what are some of their socioeconomic conditions, so that we could begin to come in and invest. And we did. And this was something we initially put out $500,000 to some of our communities that were most in need, and really leveraged the technology that we had already started by looking at where are the most vulnerable and who needs us the most in that mitigation phase. And we were able to use our dashboard for immediate response. But in addition to that, now we're beginning to build on this, not only identifying where we have resources, where some of those confirmed cases are, but as we think about recovery, mitigation, really prevention and preparing for the next hope, whatever comes in our community, that we will really have the intelligence that we need and be able to take, some of the existing data of what's happening in our communities and pull that into really what we call our data ecosystem. So, that was a great opportunity for us to leverage that existing technology and work with a lot of our community partners. And, as we think about not only the first wave, is, most of us are responding to right now, but, we clearly know that people have had, restrictions on resources, whether that's health care resources because of the shelter in place or safer at home orders, or restriction in just some basic needs like food, that there is that wave of understanding how our communities are being impacted with some of the urgent conditions from resource restriction, and how are we preparing and how are we looking at this second phase or second wave of what's happening. And then especially those that have had chronic conditions and that they've had their care that's been interrupted due to the pandemic. How are we beginning to identify where they are, where we can provide those resources, looking at a lot of our virtual technology. Really one of our major initiatives, and something that had been identified in all of our community health needs assessment, is housing instability and those experiencing homelessness. So this was something that we really wanted to make sure that we understood what was happening, where some of these alternative care sites are, and how we can continue to support that over the next 18 months. And then really preparing for what that fourth wave, and really looking at some of the economic burdens that are unfortunately going to be impacted by the pandemic, some of the mental illness that a lot of this trauma, and it really is trauma that a lot of our community members are experiencing, as well as some of the family trauma that we're seeing in as a result of some of the shelter in place. And then really looking at burnout, not only of our frontline heroes, our caregivers that are there day in and day out, but our community workers, those that are working in some of those alternative sites. How can we begin to use location intelligence to really look at where our resources are needed most, and to be able to make those decisions with confidence that we can begin to evaluate whether or not it's being impactful. And as we move forward, we know that we can't do this alone. So we've been partnering with other major health systems, to really begin to look at how can we leverage all of our resources, because the need is so great, not only with, the expected surge in Medicaid recipients, and perhaps those that are uninsured due to the, some of the layoffs and some of the furloughs in our communities, but also some of the ongoing, basic needs with food insecurity or those that are experiencing homelessness. How can we work together to begin to leverage and see who's providing what where, and that we can make the most of the resources that we have in our community. So we'll also want to know, as I mentioned in some of the other waves, we're going to have newly vulnerable populations. We need to make sure that we're not investing in investments that aren't working. And most importantly, how do we partner with our communities? How do we identify those not-for-profit partners and begin to strengthen them collectively and understand what their needs are and what the rapidly changing needs of our communities are? A 3-year, community health needs assessment isn't going to cut it. We really need to begin to look at, data now and beginning to look at real-time data in our communities with the intelligence of location. And so we're really looking forward to the next steps of being able to be more efficient from a community perspective. So I'm going to turn it back to Este, and we'll go through and see if you guys have any questions for us.
Great, thanks, Dora. So if you do have questions, please do put them in the chat box at this time. We'll keep an eye on that. But I have a few questions of my own, Dora, so I'm going to start there, if that's okay with you.
Absolutely.
All right. So you mentioned that you mentioned housing instability and the homeless crisis. And so how do we take this disruptive moment and transfer that into what could be a generative moment in building long-term solutions for your populations that are experiencing homelessness and have housing instability? How do you do that?
Yeah, well, if you think about all the energy, all the resources, and all the community partners that are investing in, ensuring that, there's safe places for those that are experiencing homelessness and that are COVID positive or under investigation. Many of you in your communities have probably seen these alternative sites, whether they're in a hotel or whether they're in an RV park. You think of all those investments from all of our, diverse community partners. And how do we, really translate that into some data that's, into actions that are working, Este, so that we don't go backwards, that we have clearly seen through COVID that the inequities that we knew existed because we'd already mapped them, we know where some of the, vulnerabilities in our community were, that they were just magnified through this crisis. And so we know that now, we've been able to map that. So how do we translate that into action, not only within our health systems, but within our public health departments and with other housing authorities, so that we can move forward to a sustainable solution, not just a response to crisis?
So in several ways, it sounds like you're taking very much a teaming approach. The health system's not doing this on its own. That's great. And I think your point about how, these things that we already knew, all of the studies of social determinants of health and the acknowledgement that it's important are only magnified at this time. And we need to be really responsive, I think, as you said, to mitigating those inequities.
Absolutely. And, with the data, it's just incredible to be able to see how we can build a more equitable framework within all of the community partners.
Now, you mentioned, I think it was in your last slide, you were talking about partnering with other health systems and responding sort of broader population and probably all of those health system organizational needs. And so could you say a little bit more about what you're doing there?
Certainly. Well, really, we just, many of us as large health systems just went into immediate response. And so we had a group of us that had been, already working together in terms of looking at technology and how do we leverage, because when in communities, if, we're improving the community health, all boats rise. This is really a space where we need to collaborate and work together. And so we activated, again, those relationships, what we'll be doing is taking the platform that we built at Providence St. Joseph Health and partnering with others to see where, all of our investments as health systems, and we've got Kaiser, Common Spirit, and Adventist Health as some of our initial partners beginning to look at how do we maximize the investments that we're making so that we're not doing duplication, that we're understanding how we can co-invest with better results. And then also, how can we look at some of our communities in terms of who's being missed? We make assumptions on that we're serving, but if we really have the data in front of us and that we can map, as you say, map the communication, we really can be more impactful with the limited resources that we're all going to have.
Yeah, absolutely. And I know that we have some audience questions coming in, but I do want to ask you one more question before I turn it over to Robbie to pull in some of those audience questions. And so I want you to be a futurist for a moment. What do you anticipate as some of the medium and long-term impacts of COVID-19 in our communities?
Yeah. So let me be an optimistic futurist, Esty. So
Thank you.
not only a futurist, but unfortunately, I think it's given us a moment to reflect. It's given us a moment to see the inequities in our community. So as we think about investments moving forward, can we think about investments that are, one, having an impact? So often I think we look at community health and are investing in things that don't necessarily have the dose, intensity, and duration that is needed to make the sustainable changes that we have. So if we're to, really be serious about rebuilding, how could we rebuild collectively and together with really serving some of some of the greatest needs in our communities, and not only serving the greatest needs, but a lot of people are furloughed and out of work. So how can we transfer that energy and our reinvestment to serve a broader good in our communities, so that this isn't something that we do in response to COVID, but it's how we do business in terms of developing our communities collectively.
Yeah, no, I like the more optimistic view, and I think that so much of this response has taught us where we need to strengthen our systems, where we need to pay more attention to our communities in different ways. And my great hope is that we don't let those lessons pass by the wayside, that we actually learn them. And when we're in a position to take broader action beyond the response that we're doing now, that we strengthen our systems for whatever's coming next. We know there's always a next time. And I was particularly struck by your slide that showed the fourth wave being a lot of mental health concerns. I've been thinking a lot about folks in substance abuse recovery programs, chemical dependency programs, and those are a different kind of communal living situation that I don't think has gotten a lot of media attention at this point. But I think many of those are important, and we need to keep our eye on those. So I'm glad you brought it up.
Yeah, as we look at the onion, there's going to be a lot of layers there of years of chronic underinvestment that we need to really begin to address.
Yep, an apt example. Robbie, let me turn it over to you to see if we have some audience questions that Dora and I can respond to together.
Yeah, we've got a few. So the first question was a follow-up. You mentioned that Esri was providing the free resources, and there was a question about how do you actually access those resources and software?
Yes, so yes, free. So you go to the COVID-19 GIS Hub. So again, that you have a resource on your screen that right now that gives you information specifically to get to the hub. You can go to coronavirus-resources.esri.com. Robbie, maybe you can put that in the chat for everybody to have immediate access to. And the very front thing you see there is a thing that says request GIS assistance. You can go there to get assistance, or you can go to the top right-hand corner of the hub where it says resources. When you click on that page, it's going to take you to the different solutions I mentioned, and you can select one or any of them that are relevant for you. and request them that way. It's going to kind of all filter you to the same place, but a few ways to get there. So we're happy to provide those during this time. I think people are getting a lot of value. Thousands have already downloaded and used them.
Awesome. Thanks for addressing that. And I had another really interesting question come in. Dora, you mentioned this idea of newly vulnerable populations. What are some of the indicators of who those newly vulnerable populations would be?
Yeah, no, that's a great question. As we look at, looking at, increase the surge in Medicaid enrollment or the uninsured, those are clearly going to be, key indicators. But also looking at, I hate to even mention this, but evictions. If you think about, we've really had used our voice as a health system to support moratoriums on evictions. So, I think, and also those that, a lot of our vulnerable seniors and a lot of our low-income communities that don't have access to food and can't get out. And, even as we move into, opening up our communities, there's still going to be, parts of our, of our population that are still going to be vulnerable and need to have access. So, I think food, some of the uninsured, and then also housing.
All right, well, thanks so much to both of you for presenting today. We really appreciate everyone's time, and thanks to everyone who attended this webinar. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you would complete that and provide your feedback. You'll also receive a follow-up email within 24 to 48 hours with the link to view a recording of today's webinar, and as Esty mentioned, she'll also be providing her slides. Our next webinar in the series will actually take place on May 28th and will feature speakers from both Emeris and Centera Healthcare. If you'd like to learn more about this webinar or our session on June 25th with IEHP and the University of South Carolina, please visit the URL on screen. On behalf of Esri and our presenters, thank you for joining us today and have a great rest of your day. Thanks so much, everyone.
Bye, everyone.
Thank you.